My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Welcome to COAG Conversations. Our guest is Professor Emmanuel Favaloro. Professor Favaloro is a principal hospital scientist at the Institute of Clinical Pathology and Medical Research, Westmead Hospital, and a founding member of the Sydney Centers for Thrombosis and Hemostasis. He's affiliated with both Sydney and Charles Sturt universities and is current editor-in-chief of seminars in thrombosis and hemostasis. The title of Professor Favaloro's series is The Many Faces of von Willebrand Factor, or von Willebrand Factor, ADAMTS13, Malignancy and Beyond. Conversation number 2 is entitled Von Willebrand Factor and ADAMTS13, Tumor Progression and Beyond. So let's start. Dr. Favaloro, in our previous session, we examined von Willebrand factor deficiency in malignancies, and it appears from your publications that there's more to the story. Is von Willebrand factor somehow involved in causing or aggravating a malignancy? Are we seeing von Willebrand factor elevation in malignancies?
So this is a great question, George, and I did spend the first conversation talking about acquired von Willebrand syndrome and the loss of von Willebrand factor as a bleeding risk. Now, we could also talk about the other face of von Willebrand factor in terms of its as a risk for thrombosis. So I didn't mention, I don't think in the first talk, that von Willebrand factor is stored in endothelial cells and platelets, and that upon endothelial cell activation, potentially due to a variety of stressor events, von Willebrand factor may be released from endothelial stores where it's housed in what we call the Weibel-Palade bodies, the Weibel-Palade bodies. Now, this von Willebrand factor, as it's released from the endothelial cells, is represented by very large forms of von Willebrand factor, which we call ultra-large von Willebrand factor. Now, normally the activity of von Willebrand factor is modulated by the presence of the so-called von Willebrand factor cleaving protease, which is also called ADAMTS13, which stands for a disintegrin and metaproteinase with thrombospondin type 1 motif member 13, and that's why we just call it ADAMTS13. It's a lot easier to say. But as I said, it's also known as von Willebrand factor cleaving protease. Now, in periods of ongoing stressor events, this can be in conditions of infection, such as COVID-19, for example. The ongoing endothelial stress that we see results in the release of so much von Willebrand factor that it may overcome the capacity of the ADAMTS13 to cleave it or to moderate its size and lead to a consumptive state in which the plasma ADAMTS13 is reduced. Now, in terms of the malignancy side, there's growing evidence that VWF is not just a passive observer in malignancy, but rather an active player. Now, as I said in the prior conversation, I did talk about acquired von Willebrand syndrome due to absorption on some malignant cells or due to autoantibodies, but it goes way beyond that, and it also may contribute to the malignancy.
Thank you for that overview. In some of our previous COAG conversations, we've learned quite a bit about von Willebrand factor and ADAMTS13 levels in COVID presentations. So could you please expand on this a little bit, talk about the ratios and so forth?
Sure. So in the first conversation, I talked about VWF activity to antigen ratios, such as glycoprotein 1b to antigen or collagen binding to antigen. Well, we can also use the same concept to talk about VWF to ADAMTS-13 ratios, or we could talk about this relationship as the von Willebrand factor ADAMTS-13 axis. So it's usually talked about as the VWF to ADAMTS-13 axis or ratio, but sometimes some publications talk about the reverse, so the ADAMTS-13 to VWF ratio or axis. Now, I prefer to talk about the VWF to ADAMTS-13 axis because it's the VWF that ultimately ends up leading to the problem, so either bleeding or to thrombosis. So an excess of von Willebrand factor, so it can be just a global excess of von Willebrand factor, or a relative imbalance of VWF to ADAMTS-13 actually represents a risk factor for thrombosis, in specifically microthrombosis, so in other words, organ thrombosis, with resultant organ damage or failure. Now, this is a condition that we know exists in COVID-19, and it's also likely very important in long COVID-19, but hasn't actually been explored that well in long COVID. Now, I think we'll talk more about this axis in the next session, but we will mention briefly also in this session that the most extreme example of the imbalance between VWF and ADAMTS-13 is a condition we know as thrombocytopenic purpura, or TTP, where ADAMTS-13 levels are less than 10%. Nevertheless, in severe COVID-19, there is an ongoing activation of the endothelial system, which leads to an increased release of von Willebrand factor, an increased level of von Willebrand factor in plasma, and also the eventual exhaustion of ADAMTS-13. And this leads to a great increase in the VWF to ADAMTS-13 ratio, and thus promotes microthrombosis.
Thank you. So is the VWF ADAMTS-13 imbalance that we see in TTP also implicated in malignancy? Which malignancies? And is this different than the mechanism for the acquired von Willebrand syndrome mechanisms that we discussed last month?
So, sure. So in the case of malignancy, we have to recognize that there is a small risk of acquired TTP, but the relationship between VWF, ADAMTS-13 and cancer is much more complex. We spoke about acquired von Willebrand syndrome in the first conversation and how this can arise in malignancy, in particular in hematological cancers. However, the opposite is also true, and von Willebrand factor levels may increase in certain cancers, including breast, colorectal, non-small cell lung cancer, gastric cancer, prostate cancer, and acute lymphoblastic leukemia. Such cancers release a variety of endothelial cell activators. So in other words, they activate endothelial cells to release von Willebrand factor. Now, these may include inflammatory cytokines, matrix metalloproteinases, and pro-angiogenic mediators, such as vascular endothelial growth factor A. Now, VWF may also be released from some of the tumor cells, as well as a tumor microenvironment in certain cancer patients, in addition to the VWF that's released from the usual sources of endothelial cells and megakaryocytes. So in other words, we can get a bigger release of von Willebrand factor in some of these malignancies. So some of the non-endothelial origin tumor cells that have been shown to produce von Willebrand factor, for example, osteosarcoma, colorectal cancer, and hepatocellular carcinoma, gastric cancer, and gliomas. So they've all been shown to produce von Willebrand factor, and then that von Willebrand factor, if it's in excess or if it's in a particular environment, can lead to thrombosis or microthrombosis.
Well, it's fascinating to think of these various carcinomas producing some form of von Willebrand factor, and it seems like the inflammatory cytokines and the various mediators are implicated in many adverse events. Does that tumor-produced von Willebrand factor participate in thrombosis, or does it add to the tumor pathology?
So again, a very good question, George. And if you will permit me, I'll put up another slide to perhaps give you a bit of an overview of what might be happening. Okay, so in this slide, I'm just showing you a pictorial representation of some of the events that may be occurring in cancer. So in cancer, depending on the cancer and depending on where it is, can lead to either an increase in von Willebrand factor production or to von Willebrand factor absorption or antibodies against von Willebrand factor. So if you have a von Willebrand factor absorption or antibodies against von Willebrand factor, then you can get an acquired von Willebrand syndrome, as I talked about in the last conversation. And here, although I only mentioned in the last conversation a reduction in von Willebrand factor, really we can also look at this in terms of the von Willebrand factor to Adams TF13 ratio. And in this situation, the VWF to Adams TF13 ratio is lower, and that represents a bleeding risk. However, in certain cancers, what also happens is that you can increase in von Willebrand factor production. Now, this von Willebrand factor production actually can then have a number of other unwanted side effects. So one of the properties of von Willebrand factor that we know does occur, but I didn't mention in the first conversation, is that of angiogenesis. And we know this partly because in patients with von Willebrand disease, they have a failure of angiogenesis, particularly in the gut, or they have problematic angiogenesis can lead to gut bleeding. So where you have an increase in production of von Willebrand factor, then you can increase in angiogenesis. And that actually can then lead to a tumor progression or formation of metastases, because that cancer then can spread down the newly formed blood vessels, which is what angiogenesis means, the formation of blood vessels. Then you can get a tumor progression or metastases occurring. The other thing that can happen is that von Willebrand factor can act to some extent as what we call a platelet taxi. So platelets are actually implicated in tumor progression as well. They also assist in promoting the progression of tumor or metastasis, because they can actually help carry some of those tumor cells to other sites. And von Willebrand factor is thought, if it's an increase, it's thought to actually contribute to that process whereby those platelets can actually carry those tumors to new sites. And then again, you can get metastases from that tumor progression. And in all those situations, what happens is when you have an increase in von Willebrand factor, you can also get an increase in the von Willebrand factor to Adams TF13 ratio, and that is a thrombosis risk.
Oh, it seems like the complexity of von Willebrand factor's relationship to inflammation is quite striking. Does Adams TF13 itself also have a direct role?
So von Willebrand factor, as I mentioned, is involved in angiogenesis, or the formation of new blood vessels. And as I indicated before, gastrointestinal bleeding may be caused by the lack of von Willebrand factor due to vascular malformations called angiodysplasia in certain forms of von Willebrand disease. Conversely, increased angiogenesis caused by local accumulation of VWF may promote tumor progression. Now, also, Adams TF13 or its deficiency may also play a role, since this will lead to an increase in the high molecular weight forms of von Willebrand factor, which are better able to support adhesion to platelets. Similarly, it may be possible the determination of VWF to Adams TF13 ratio, rather than looking at each individually, may improve in time to be a potential marker for cancer risk in prognosis. So in other words, not just looking at von Willebrand factor, not just looking at Adams TF13, but looking at their combination. And the Adams TF13 the VWF to Adams TF13 ratio is a great tool for that. If the audience wants more information in regards to the concepts I've covered, they are quite welcome to read some of my latest papers, and I'm happy to provide copies of any of those papers who ask, and I will provide my email in the transcript for this conversation.
Very good. This has been very interesting, and this concludes our second conversation. Dr. Favaloro, thank you for your expertise. We encourage participant questions and comments, and there's a link on the Biomedica Diagnostics website for you to forward your questions or comments. We will incorporate Dr. Favaloro's email in the transcript of this talk also. Please join us next month for conversation number 3, entitled Von Willebrand Factor and Adams TF13, Thrombotic Mechanisms and Cardiovascular Diseases. Thanks to Biomedica Diagnostics for sponsoring COAG Conversations, and thank you for participating.
Once again, thank you, George, and thanks to Biomedica Diagnostics for allowing me to partake in these conversations.